I just had the distinct privilege of speaking once again with Andrew Kessler, principal of Slingshot Solutions. He's an attorney living and working in Washington, D.C. to ensure access to behavioral health care for all Americans. The topic of our discussion is both timely and concerning. It is a discussion of the leaked pre-decision budget of the Administration for a Healthy America. And this budget, if adopted, lays out a set of cuts and changes that would fundamentally reshape the delivery of healthcare in the United States. I went into this conversation feeling relatively concerned and unsure about what this document means. There's been a lot of news coverage about it. There really haven't been very many answers around it. It's something that's complicated and involved. It's lengthy, and it's also difficult to parse. It's hard to know by looking at it on its face how it differs from today's healthcare policy of the Health and Human Services Administration. As you'll see in this discussion, Andrew Kessler breaks that down in a way that's much easier to understand, and particularly through the lens of behavioral healthcare. What might it mean if this budget comes to fruition, if it is passed, and if that becomes policy? This is a topic that is complex as it is consequential. And I think that what you'll see during this discussion is that we should feel heartened that we have people like Mr. Kessler working on our behalf. Clearly, he is an individual possessing towering intellect, an encyclopedic grasp of his subject area, and a true passion for humanity and for behavioral health care. And so please join us as we delve into what this pre-decision, not yet formalized budget could mean for the delivery of healthcare throughout the United States and behavioral healthcare in particular. We were talking about a month ago, and at that time, and coincidentally, I think that day, it was when announcements were made that significant cuts were happening at SAMHSA. Budget cuts were happening, RIFs, were happening, and a lot of the change that's perhaps started to roll out, at Health and Human Services and other departments started. What's happened since that time, in the month that we talked?
Yeah. So when we last talked, we kind of got the sense that there were going to be reorganizations within Health and Human Services. And all we got was like a one-page document saying this is coming, and then we didn't know what else would happen. And I believe in the last time we talked, I said what's really going to tell the tale is the FY26 budget. Then shortly after that, after we spoke, a document was leaked, we don't know by whom, that gave us some insights into that budget. And I'm going to have to pause for a second and take this opportunity to give almost a civics lesson, because these are things you don't learn, and whether it's high school, college, whatever, these are the little things about Washington that Schoolhouse Rock, may have left out. The Office of Management and Budget in the White House is responsible for budgets that go out to all of the executive agencies, whether it's labor, commerce, energy, and then the agencies each review their budgets. And when these documents go back and forth, OMB's recommendation for funding, HHS's response to that recommendation, it's called a passback. It's exactly what it sounds like. The document is passed back and forth. So it's called a passback. Very few people outside the Beltway even know these exist. Very few people inside the Beltway even know these exist, unless you live your life in the appropriations bubble. So these were never really big news, because usually the passback documents, when they'd be passed back and forth between OMB and the agencies, little changes were made. Let's tick this, let's adjust that. Never were drastic changes ever made in the passback. So you could always get a sense that when you heard about a passback going on, the budget was coming soon. And you would try to get information from people in the agency, people from OMB, hey, anything on the passback. And when you were trying to get information in the past, it was always just timing, because the timing would tell you when we can expect something. It was never really about the numbers. It's way too late for that, because whether you work with OMB or whether you work with the agencies, by the time these documents are going back and forth, the numbers, for the most part, have been set. So when this passback between Office of Management and Budget and HHS was leaked, I thought, and many of my colleagues thought, this could be the first time in history, or at least in my several decades in Washington, that a passback was leaked. So to show you how significant it is. And what we ended up with was what we think a blueprint of what the Trump administration's the Trump administration's HHS, what their goal is to have it look like. And the original document by Mr. from HHS, which I believe was put out in Mr. Kennedy's name, was that several agencies would be folded into one larger agency, the Administration for a Healthy America, AHA, or as we're calling it around town, AHA. This included SAMHSA, the Substance Abuse Mental Health Services Administration, HRSA, the Health Resource Services Administration, which was responsible for, in large part, the federally qualified health centers around the United States, and also the Public Health Service Corps. Those are both under the auspices of HRSA. And a few other agencies that I am not terribly familiar with, NIOSH, National Institute of Occupational Safety and Health, and a few other smaller, I think a total of 5 or 6 smaller agencies would be folded into AHA, and AHA would be organized under 5 categories. One, I believe, is maternal and child health. One is chronic disease. And for the purposes of my work and your work, one heading was mental health. And a lot of us who work in substance use disorders were wondering, what about us? Turns out, and in a surprise to no one, we're probably under mental health, because unfortunately, a lot of policymakers still consider SUD and mental health one category. And even though experts in the field realize that there's a lot of overlap, there's a lot of differences too. So what we started looking for in this document was what made the cut and what didn't, because it's been all over the news. It's not germane to HHS. It's been all over the news that the current administration wants cuts. Where they come, how they come, that remains to be seen. So the first thing we looked at, or the first thing I looked at, many of us looked at, was what happens to the mental health and substance use block grants. These are the grants that go out to the states on a formula every year to basically fill the holes that Medicaid can't fill when it comes to services. The good news is that based on this document, and this document alone, which could change because it's not the final document, the substance use and mental health block grants appear to be intact. In addition, the other grant that's very important to people in the SUD community is the State Opioid Response Grant. That grant appears to be intact. And that's at about $1.575 billion. I believe the SUD block grant somewhere around 1.9 something billion dollars. Those are both funded at last year's levels. By and large, no complaints from the community given the just about everything else when it comes to discretionary funding from SAMHSA seems to be in a bit of trouble. I have not had time to mix and match every single program from last year's budget to this year's budget. I'm getting there, and maybe next podcast. But on the mental health side, we know for sure that the 988 hotline is intact. Garrett Lee Smith suicide programs are intact. That's great. Everything else could be some issues. So to give you an example at SAMHSA of what we're dealing with, on this page, which I'll just read to you, and maybe I can send you a copy of this and you can send it out with the podcast. In the Center for Substance Abuse Prevention, the programs slated for elimination, and I'm sorry I don't have funding amounts on here yet, but for an example, the Tribal Behavioral Health Network, which helps prevention in Native American communities, the Minority AIDS Initiative, and the STOP Act, which is one of the very few programs in this country that is aimed at stopping underage drinking. This is a program that's been around for, I want to say, a good 20 years. That is one of the very few programs that focuses only on underage alcohol. That is slated for elimination under the Trump plan. And I'm going to get to the other semantics in a minute. Under the Substance Abuse Treatment Division, programs potentially slated for elimination or proposed for elimination are naloxone distribution programs, overdose prevention, first responder training for naloxone, technical assistance to build the peer support workforce, the Minority Fellowship Program, Building Communities of Recovery, which is a program funded at about $18 million, which gives grants to community-based organizations so people entering recovery can find the services they need to not just stay sober, but to get their lives back together, access to programs, and assistance in housing, vocational training, fellowship, whatever it may be. Youth and the Youth Prevention and Recovery Initiative was also slated for elimination. On top of that, the final elimination we see under SAMHSA are grants to help develop certified community behavioral health centers, which have been around for almost, I want to say 10 years now, and kind of follow a federally qualified health center model for behavioral health. They accept Medicaid. There's been pilot program. There's been hundreds of millions invested in this. They're a tremendous success story, but SAMHSA grants to help expand these centers seem to be proposed to be on the chopping block. And I want to make clear to your listeners, everything I just said is a proposal. So that's where we're at with this document, and that's kind of the current state of play.
Wow. I mean, have you seen, since that time? So this is the proposal. We can kind of get into that, what that might mean. And again, it is a proposal. It is not yet the budget. It's not yet law. Have you seen other impacts, along the way, continued cuts? I mean, we hear about, in the news, agencies being impacted, and individuals either deciding to retire early or be risked.
Most of the impacts, first of all, yes, most of the impacts we're hearing about are not based on this document yet because it hasn't been implemented, although we hear different rumors every day about the administration's attempt to possibly implement this before Congress has their say. That's rumor, conjecture. I don't want anyone to take that as the word. The impacts we're seeing were from the last round of what we called, I think we discussed, a clawback. That was money that was sent out to the states through SAMHSA as a result of COVID funding back in 21 that they were told they had 4 years to spend. They had till September 30th of 2025 to spend that money. Some of it hasn't been spent yet. That money was pulled back by the federal government, and we have seen impacts there. I can't cite chapter and verse, but the answer is most certainly yes. Even though a federal district court in the United States put a freeze on that clawback, we have heard stories of states just saying, we already canceled these programs, and then to start them up again would be even more expensive, and there's definitely been a ripple effect. So when it comes to the money that was clawed back, the $1 billion nationwide under SAMHSA, we have seen some impact. But when it comes to these programs, by the letter of the law, all those programs I just mentioned that could be potentially slated for elimination, under the continuing resolution that passed in March, these programs should be funded through September 30th, 2025, by the letter of the law. So we shouldn't see the impact of it just yet. How it plays out, things change every day.
Okay. And again, even though this is a passback, as you mentioned, and this might be somewhat down the road. I mean, there's still, is there room for negotiation? This, as the bill progresses, I mean, it seems like, is there time to advocate for change? I mean, how?
If you're talking about advocating for change within the administration, and by the administration, I don't mean only the White House, but I mean the OMB, the Office of Management and Budget, and HHS, and their back and forth, I would have to say no, because when that process starts, you have to understand how complex and intense and closed to outsiders that process is. OMB, those of us who do this, OMB is always open to talking to advocates, but they always give you a hard deadline. They say, if you've got something to say, if you've got questions, if you've got priorities, talk to us before, and they give you a date, and that usually is in September, because September to whenever is the passback phase. That calendar really doesn't apply because we're in a new administration. This administration wasn't in place in September. So OMB, the new OMB headed by Russ Vaught, and his passback process didn't start until January or February. In any event, I'd have to say, is when you say to me, is there any chance for advocacy? When it comes to advocacy to OMB, to HHS, I'd say save your strength. Absolutely not. The advocacy is supposed to come when this is submitted to Congress. That's when people like me, that's the firing gun. That's when, we're all sitting around waiting for the budget to be released. And once it hits and we open it and go through it, that's when the firing gun starts and we get to Congress and we say, and we go through point by point. Now, this is where it gets tricky. Usually in more, I don't want to say normal times, but in the past, there was a certain calendar and a certain expectation that a timeline would be followed. Usually the president's budget would be released sometime in late February, maybe early March. And around that time, House and Senate offices would throw open their doors and their websites and say, any advocacy you have on the president's budget, let's talk. And because we have a new administration, we knew that the budget wouldn't be ready by February or March, not even a skinny budget. We knew it would be more likely April or May. However, Congress is very used to their system. So Congress threw open their doors and their websites and everything else on their regular timeline, February, March, April, and said, any requests you have, get it into us. And we had no idea what the president's request was going to be. So we were kind of flying blind. And this isn't the first time we've done it, because as we now live in a world where CRs, continuing resolutions, are the norm, and the budget is never done on time, the whole calendar has kind of been cast aside and things happen when they happen. So there's a saying in Washington, the president proposes and Congress disposes. But that's not really true, especially when the president and Congress are all of the same party. That's true, let's say, when you had a Biden White House, a Democrat Senate, and a Republican House. Yeah, Congress is going to come up with their own thing and whatever, but members of the president's party, if they have a majority, are going to give a lot of credence to the president's budget. So if this is what the president's budget ends up looking like in the end, you can be fairly confident that several members of the president's party, especially in the House, are going to say, we back the president's budget. Now, they may have pet projects or ideas they have where they want to see a little bolster. They may have projects they don't like where they want to see them come down. But there's no obligation for Congress to follow the president's. The Congress comes up with their own appropriations, but don't be fooled. Yes, the president's budget does have a degree of impact on their decision.
So it is different because now we don't necessarily have different parties in office. It's a more unilateral membership there. And so what does that mean for this? Is it
well? So let's talk about the process. Let's talk about this document and everything I mentioned. We advocates who have all these programs I listed, each one of them has an advocate or 2 or 3 or 10 in Washington. And we have been spending the last several months making our requests of Congress saying, please fund these programs at whatever levels. Let's be honest, we have not been very ambitious this year. Our requests have been very modest. No one is expecting large, if any, increases in any of these programs. We know what the fiscal environment is. We know what the political environment is. But, our biggest question when this document came out was, our question for congressional staff was, well, if the programs I've been making requests about pertaining to are no longer SAMHSA, but they're AHA, what does that mean for my requests? And we've been told, don't fret too much over that. Don't fret too much over the label of where they end up. The question becomes, for a lot of us, they said, look, if you requested a program and it's just going to be moved, we're going to take into consideration that request. If you made a request for a program that's been slated for elimination, I can't tell you how many times in a president's budget, a program has been what we call zeroed out, which means canceled. The White House says, we don't want that anymore. And Congress funds it anyway. Par for the course. Totally normal occurrence. Totally normal occurrence. And the opposite too. The president says, I want to fund this. And Congress says, guess what? Zero. At the end of the day, Congress has to pass an appropriations bill. The president has to sign it, just like any other bill. So there's always going to be a give and take. Mm-hmm. So the question becomes, how much of this blueprint does Congress follow? The conventional wisdom right now is the House will follow it closer than the Senate. Mike Johnson, we know his relationship with Trump, solid. That's not to say Mike Thune in the Senate doesn't have a good relationship with Trump, but what they've had to do in the House to push a fiscal hard line. The House Republicans are almost always more fiscally conservative than the Senate. You also have more special interests in the House because you have 435 members versus 100. But the Senate gets more concentrated action because you've got 2 senators from every state hearing from special interests, whereas the House, you only have 1 member from each district hearing from a specific special interest. Or at least that's the way it works in theory. Obviously, if you're a committee chair, you're going to hear from special interests outside your district, on and on. What I am looking for is when the House puts out their report, if they do, each body is expected to produce a bill, and it's accompanied by a report. And the report gets into the nitty-gritty. This program, we're funding at this level for these reasons. The report is really what makes or breaks the appropriation, because that's where you get into what Congress is thinking. If everything goes according to plan, we're going to see a House report and a Senate report. In the way it's supposed to work is then those 2 bodies need to get together and produce 1 bill that they can send to the president. That hasn't happened in a while. Forget who the president is, forget who's in charge of Congress. It's been a long time since we've seen in the HHS arena where I live, the House and Senate produce 1 bill and send it to the president. We've seen a lot of omnibus, which is a lot of different spending bills lumped together. We've seen year-long CRs like we're in right now. We get a lot of different variations.
But that is somewhat dysfunctional. I mean, I don't want to say dysfunctional, but that's not the norm. It shouldn't be the norm.
It's not the way it's supposed to
work. Okay.
Right.
Yeah.
Right.
Yeah.
So my focus, and this is just me, me doing my job, I'm most curious about the Senate because even though the House appears to have a slim majority, the Senate is also a slim majority. And we are very curious as to how members of the Senate will react to this HHS organization, because the states are going to be hit very, very hard by the loss of some of these grants, not only in SAMHSA, I'm talking about across all of HHS. This proposal eliminates 1/3 of all HHS funding. So I can't even get into how it impacts the CDC, the NIH. I can recommend other people for your podcast to talk about that, but we're sticking to behavioral health right now. The amount of concern over the public health infrastructure proposed by this document is, I kid you not, through the roof.
Wow. So I mean, so there is concern. I mean, we should know that.
Tremendous.
The people who do understand this issue, and it's a very complex one, which is why one of the many reasons your insight is so important. But there are people specializing in it. There is concern. I mean,
tremendous concern.
Okay.
Yes.
How is there precedent for how much of a change this is in your experience? I mean, have you seen a budget proposed like this, even though it's a preliminary budget? Okay.
This is earth-shattering. Let's put it this way. Usually, let me give you just a couple of examples. Last year, in the House appropriations proposal, there was a recommendation of the restructuring of NIH to reduce the number of centers from 27 to, I think, 8 or 12, I'm not sure, and to make it more streamlined and more efficient. That was in the House proposal, and it was very detailed. It did not appear anywhere in the Senate proposal. So it was a non-starter. And we've heard since that was more of a trial balloon. Let's see what kind of reaction we get from this. A proposal similar to that is in this document. And that's just a couple of pages of this 60-something page document. So that proposal for restructuring last year, which had all of the HHS community, I wouldn't say freaking out, but very, I don't want to say nervous, but talking. We were talking. It was a subject of conversation. It had all of us talking. A proposal such as that had all of us talking. And that's just a couple of pages in this document. This is seismic. This is absolutely seismic because you're talking about taking five, and this is another thing this is another part of the civics lesson that, again, you didn't get on Schoolhouse Rock. And for your listeners in the age of 46 to 62, maybe they get my Schoolhouse Rock reference. I don't know. Yeah, anyway. My kid, my teenager likes to kid me whenever I say I'm going to the Capitol. My kid says, say hello to the Bill if he's sitting on the steps,
Right.
So this is seismic. So take into account this. SAMHSA is an $8 billion agency. HRSA, another several billion. CDC, another several billion. And they're talking about basically I guess in business it'd be called a leverage buyout, breaking it up and taking the parts and realigning them. And multi-billion dollar moving around to create a new streamlined, what they claim will be a new streamlined agency. I have been doing appropriations work since 2001. Never seen anything like this. I've seen the last time there was anything this seismic on the appropriations front in all of Washington, I would have to say was the creation of the Department of Homeland Security. Because they took border control, they took FEMA, they took and they kind of took off the parts, created and this is not an insult, but this is just a term of art, a Frankenstein's monster. And they did it the right way. Credit to President Bush, credit to Congress. Congress authorized it, appropriated it, said, here you go, and the president signed it. So in taking all these agencies, the subject we haven't even broached yet is the executive, by law, cannot do this single-handedly. SAMHSA was created by Congress. HRSA was created by Congress. NIOSH was created by Congress. All the other agencies were created by Congress. It's very, very questionable. And we haven't, in the work I do, I'm not a lawyer. I am a lawyer, but I don't practice this kind of law. There's a lot of questions flying around just in can they do this? Or does Congress need to say, because we reauthorize this agency, we get a say? Technically, based on this document, HRSA and SAMHSA and these other agencies will cease to exist. Now, I do know that the law says if Congress creates an agency, only Congress can shutter it. So by the same virtue, this new Administration for a Healthy America, AHA, if it's going to receive congressional appropriations, does Congress need to authorize it and create it? So another question in this legislation that we need to see from Congress through appropriations is, will they say, here, Mr. President, here's your AHA? I am fairly confident, although not certain, the House will do that. I have no idea if the Senate will do that. None. I have no idea. Susan Collins chairs the Appropriations Committee. And a few weeks ago, she, for the first time in a series of back and forths with the White House, because the governor of Maine made some comments to the president and there was a war of words. Susan Collins did a little flex and said, I think it was about the clawback, the taking back of the money. It's like, we're the appropriators. We decide where the money goes. And I'm not too happy. Since that comment, she's been kind of quiet. And everyone's been like, did she get a talking to from the White House, or has she just chosen to work back channels? No one knows. And believe me, in this environment of media and politics, if she's chosen not to talk to the media as much about her plans and instead prefers to work the back channels, it's not the worst strategy. But we don't know. We don't know. But we're starting to sense, at least in the Senate, at least from the appropriators in the Senate, we have a role and a responsibility, and we want to make sure it's fulfilled. So that's where the curiosity for us lies. What's the Senate going to do with this document? Are they going to give the president the changes he desires? Are they going to defund? Because let's put it this way. With all of these programs that I listed that are slated for elimination, I advocated for many of them. I sent in my appropriations requests to Congress, or I had my clients send in their appropriations requests to Congress. I had no idea at the time that they may potentially not exist. So my advocacy was more on, look at the good, it was more like, hey, how about a tiny little funding boost for this great little program? Going into an office and saying, save this program, totally different strategy, totally different mindset, and you've got to be much more granular. As much as you try in an appropriations request to say this is the positive impact on your district or your state, you've got there are hundreds of members of Congress you have to get to, and is what it is. Now, these programs, we have to get to Congress and say, keep in mind, not only do we need this funding because of the benefit to community, it's not pro forma anymore. It used to be this program, this amount, this program, this amount, this program, this amount. I'm not saying it wasn't without thought. There was thought put into it. But it's a totally different mindset for advocates right now, because you're not talking about funding for your program. You're talking about the existence of your program. I'm not saying the Yankees should sign the new, free agent center fielder. I want the Yankees to field a team next year.
Right.
A totally different mindset.
So it is. I mean, it's in a way existential to what we know today about how the system works in its totality. And I think, even for so obviously this is an evolving issue, and it has tremendous complexity. And, it sounds like even the people like yourself who are the most informed about these issues, there's a lot of uncertainty, and we have to see, and from many vectors, and not only about the actual content of this potential passback, if that's what's actually proposed, but the process by which it might be adopted, and the extent to which it might be adopted in its totality. But let's say that it were, or let's say that it the spirit of this were passed, and let's say that this were to move forward. I mean, what would that mean? One of the things that you've already pointed out, which is so astute and important, and I don't think that people really understand, is that notion of seat at the table. How do you get a voice if SAMHSA's gone? Where does that live?
I can't remember if we talked about this in our last podcast, but it bears repeating. One of the former directors of SAMHSA was a man by the name of Charles Curry, who has since become a good friend of mine. And he said when Tommy Thompson was the HHS secretary, and he'd go around the table, especially in times of emergency, HRSA, the safety net, especially for rural areas. What do you need? What do we have to do? CDC, from a perspective of data, what do you need? What do we have to do? SAMHSA, behavioral health, what do you need? What do we have to do? If that voice is lost, we lose a lot of the progress we've made over the last several decades of being part of the conversation. Use whatever saying you want to say. My friends in the mental health community say no health without mental health, and it's kind of like that's something that resonates. SUD, same thing. If this AHA comes to be in the form that they see it, there will be a mental health division. But as I said, unfortunately, when you place substance use disorder under mental health, it almost becomes secondary to mental health. Even if when you say mental health, I mean mental health and SUD, it's not the same. Words matter. Labels matter.
That's why there is behavioral health, which addresses both mental health and.
If they created this new AHA and instead of mental health said behavioral health, that'd be one less thing on my plate. Yeah, but to be clear, I don't think that this document is any harsher on SUD than it is on any other area of public health. There's cuts left and right. But that mental health heading, as opposed to, it takes us back, because in the 60s, when Medicaid and the current safety net system was created, SUD was considered a mental health disorder. I think it was the ICD-8, which was how they categorized, everything. And we were in like the DSM-3 at that point, for the references for the different codes of behavioral health disorders. Now we're in the ICD-10, two versions have come and gone. We're in the DSM-5 era. Substance use disorders, even though substance use disorders and addiction are a disease of the brain, and they're a brain disease, that doesn't mean they're a mental health disorder. There's a difference. Even though SUD and mental health have high co-occurring numbers, that doesn't mean they're interchangeable. There's a difference. Do they need to be treated at the same time? Of course. But when it comes to research and community work and prevention and recovery and productivity and everything else, they are different.
Absolutely.
It really, and it's always being a wordsmith, being an attorney, people who, when they hear that SUD is a brain disease, automatically assume it's mental health. That's always bothered me because the brain's a very complex organ. And there are hundreds of brain diseases that are not mental health disorders,
Sure. Yeah, right.
So there's a
Literally a
difference.
biological,
Right,
biopsychosocial model. This is
right,
the,
or even neurological disorders. If I have
absolutely.
Parkinson's, that's a disease of the brain. The
That's right.
central nervous system is the brain. It's not a mental health disorder,
Right. And
So maybe
yeah,
the term behavioral health, or even that, is not liked by some people. But brain health, whatever you want to call it, yeah, it's. I know some people might think that the wording and the semantics shouldn't be a top concern, but it is, because in Washington, I see policymakers can't know everything. And when you go to them, let's say this, taking the basis of your question, let's say this document becomes reality. And when you go to them in the future and talk about the AHA budget, and they say, and you start talking about SUD, they might wonder, well, where does that go? And then you've got to explain to them why it goes under mental health because of a misunderstanding of the terminology, because we're still stuck in the 60s when it comes to our terminology for this.
for sure. I have, and I apologize for interrupting. I just, that does go to a core question. I mean, we happen to have, I think this bill was, or I shouldn't say this bill, but the budget was proposed by, individuals very familiar with recovery and very familiar with substance use disorder, and having lived experience and all of these things. And it goes to a question of
But was it?
potential.
But was it?
Well, I guess it's a good question. I don't know. I
Yeah.
thought, yeah.
Yeah.
Hmm.
I mean, the whole question of Doge and everything, and who, I don't know. We don't know who wrote this. It's an OMB document. I don't know if it was health experts. I don't know if it was Doge experts. I don't know if it was Russell Vaught, who was the author of large parts of Project 2025. We don't
Hmm.
know who wrote this.
Okay.
So I know, yes. Is there an HHS division in OMB? Yes, I know the people there. They usually, but they're numbers people. They're not programmatic people. They understand the programs, but they're like, they are more on the economic side. How much can we spend, and the back and forth, It's never, a change of this size and scope was not developed by these people. That I can guarantee you. Because as much as they know, if you were to say to them, hey, this program, what was it funded at last year? They'd know. If you were to say, what does this program do? That's a tougher question for them to answer because they have so much on their plate. I can tell you that, were there health experts involved in this creation of this document? It's possible. Was it the people the HHS team at OMB who's been doing this for years? I think there were other people involved. So back to your question, I'm sorry, your question was?
Well, I was kind of going toward, let's hypothesize that, maybe it's essentially that words do matter. And in fact, what underlies those words? What is the conceptual basis, on which this program is created? Because there's been a huge body of information and evidence, that supports our current understanding of behavioral health disorders, substance use disorder, and mental health disorders. And and that has led, I think, to the development of these programs and that public safety net, that addresses things like the social determinants of health, for example, that
Right.
are play direct roles,
Yes.
in recovery and support and things like
And
this.
these programs, the evidence, I would like to say, points to these programs working. We talked on the last time we talked about the decline in overdoses. Overdoses are coming down. Now, I also said when we discussed that, the lack of data is concerning.
Yes.
We don't know exactly why these overdose numbers are coming down. I would like to think, and many would like to think, that these programs play a large part in it. Now, you can't prove a negative. You can't, So if I were to say these programs played a large part in that, and someone were to say to me, prove it, my response could be, well, prove they didn't. You can't.
Right.
You
Sure.
can't prove a negative,
Yeah.
So there is that. But I would like to think that our investment in SUD prevention, treatment, and recovery does play a large part in those numbers coming down, as did coming out of the pandemic and a lot of other things. I also like to think that the economics of the illicit drug market change frequently. We see highs, we see lows, what have you. There is definitely a decrease or a greater awareness of non-opioid prescription drugs in the marketplace. There's been a lot of focus on that, on prescribing. There's been, so there's a lot of factors. I would love for the people who wrote this document, for anyone who works on this, to be able to say to me, hey, we have data and this program didn't work. I would say, show me the data. I would love to be able to go to them and say, I have data, this program did work. It's tough. Data is tough to come by in this space.
It is, and isn't that part of the issue here? Is that some of the funds that are being cut are in fact for some of the largest longitudinal studies that exist.
And here's the interesting thing, Chris. I talked about the other institutes that also took a hit. CDC took one of the largest. Inside the CDC is something called the Injury Prevention Center. And I think there were 5 or 6 different branches of the Injury Prevention Center. One had to do with accidental injury. I think firearms was in that. One had to do with like drowning. One had to do, and so there were a variety. And 2 of them were overdose, the overdose initiative, which I think I mentioned on our last podcast, funded at about $500 million, and suicide prevention and suicide data, funded at several $100 million. In this document, the Injury Prevention Center gets decimated. The only 2 that survived, the only 2 branches that survived were the overdose prevention branch and the suicide prevention branch. And they get moved into AHA. So what really, I don't want to say it confuses me so much as it irritates me, is that someone somewhere in the administration saw it fit when making a list of priorities to say, those 2 behavioral health issues, we got to preserve those. Whether they were for public health reasons or political reasons, I can't speak to. Maybe it's a little bit of both, because they both have tremendous support. Overdose is a great political issue. I have a whole presentation I've given at conferences about how our world has changed once the opioid epidemic made our issue more politically popular than it's ever been, and how people have glommed onto it like they didn't, and it's how it's been a mixed blessing. It's been a blessing and a curse. Story for another day. So someone somewhere in the administration said suicide, mental health, overdose, SUD, behavioral health, those 2 stay. So you've got someone somewhere saying this is important. In the very same document, all of these programs are eliminated, which do the same thing. They prevent suicide. They treat drug use. They prevent overdose. So on the one hand, you're saying these programs are great. And right next door, you're saying these programs got to go. And it makes no sense.
Okay. So, and this goes back to, this is unprecedented in a number of ways. And maybe that's one, is following the logic, behind what's cut and what stays and those kinds of things.
Logic is hard to find in this environment. And I'm glad you said that, because I'm going to make one more point. On April 1st, the White House Office of National Drug Control Policy released a brief statement as required by Congress. They're supposed to make a drug control strategy every year to Congress. But in the first year of administration, you just have to release a brief statement, which they fulfilled their duty to do. And there were 6 priorities. Okay. And the first 3 were more on interdiction, borders, law enforcement, what have you. All good. The next 3 priorities were prevent overdoses, prevent childhood use, promote treatment and recovery. Okay, pretty standard stuff. Nothing to get, our community was like, okay, it's all good.
Makes sense.
So one of those points, as I said, was prevent overdose, and naloxone, the overdose reversal drug, was mentioned prominently in this document. I've got the list in front of me, which I read through before, of programs at SAMHSA slated for elimination. Overdose prevention, naloxone. First responder training, naloxone, slated for elimination. So what's going on?
Mm-hmm.
That's really what has got many of us pulling what little hair we have left out.
Sure. Yeah.
You've got one document from the Trump White House saying this is a priority. You've got another document, albeit leaked, but legitimate, because every major news outlet, Washington Post, New York Times, AP, cited this, so it's got to be legit. You've got another saying, it's not so important. What am I supposed to do with that? Two documents from the same White House. What am I supposed to do with that?
Yeah. Yeah, it's incredible, and it leads to, I wanted to see if maybe we could touch on, the results of this confusion, and also there is confusion out there amongst, I think, anyone, who is looking at this issue and potentially concerned about it, thinking about, this issue. What happens, if this bill, I'm sorry, if this budget, progresses, and if it's adopted in large part. And part of that confusion and lack of understanding is certainly amongst healthcare providers. I mean, people, providers are concerned about these changes, certainly, and of course that impacts, community organizations, for example, who are providing that naloxone and naloxone training and many other, peer support services and things like this. But and you mentioned this hypothetically, if this or something like it goes through, and there isn't the opportunity maybe to advocate for, pretty important changes, to it that could protect certain programs and things. But if this happens, I mean, doesn't that kind of tear away a large part of what we would call the safety net? And again, things that address, the social determinant of health aspect of helping people in recovery, especially people with low recovery capital.
Yeah, it's hard to say safety net because that's a term of art, and that's Medicaid is more of a. I don't know if we'll have time to get to Medicaid today, but definitely it will definitely be felt. The second point you made, the social determinants of health. A lot of these programs are community based, and communities is where that social determinants really, we feel it, where we, it's not just about treatment. It's about the community saying, we're going to get you back on your feet. And nowhere is that felt more than in like reentry programs.
Yes.
People leaving incarceration, coming back into the community, giving them a chance. It is well documented how many people in the criminal justice system have an SUD issue or a mental health issue, on and on, and getting them the transitional help they need. That's where it's a lot of these programs play a very large role in reentry. That's where I think a lot of it can be felt. Also in the, when we talk about communities, as we go through this list I rattled off before, first responders, communities of recovery. First responders are community based. There's no state core. I live in Fairfax County. If I were to call the ambulance, God forbid, this evening, it's Fairfax County first responders. It's it's your county, it's your community. The youth prevention and recovery. I went to my kid's school for a program on prevention presented by the Fairfax County Police and by Fairfax County, social work services. County. That's where it's going to be felt. I mean, something you keep asking, saying, if this something similar to this becomes the standard, where's it going to be felt? Most people will tell you the states will get hit hardest, and they probably will, but some of these programs go to states who then filter it out to counties and communities. Some of these programs go directly to the communities. That's where it's going to be felt, because I said before, the block grant and the SOR grant, which are the major state funding blocks, those seem to be intact. So the states, when it comes to their general funds, the states, I don't know how much of a difference they're going to feel. It's the communities that are going to feel the difference. And this is it's a community issue. I have a colleague who was once working in some kind of community reinvestment setting, and they wanted to, enterprise zones and all that, and they wanted to build it back up. And the feds said to the community leaders, what's the biggest problem we need to tackle if we want businesses to thrive in this neighborhood? I think it was in Baltimore. And the answer from the community leaders was alcoholism. And they said, no, 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 you misunderstand us. Not the biggest health issue, the biggest economic issue. And they said, we understand. We heard what you said. Alcoholism. It affects the workforce. It affects the neighborhoods. It affects the police. It affects the hospitals. If you could get that under control and make a dent, you have more able-bodied workers. You have less emergency room visits. The police can get back to their community policing rather than be responding to drunken disorderlies.
Absolutely. Yeah.
It seems simple, but for some reason it has not been embraced. Well, not by all communities and definitely not at the federal level, but it seems simple because it is simple. And it's the communities that will suffer, and it's the localities that will suffer first.
Yeah, absolutely. And I think that there's something really profound about that, which is, I think you're right. Like, a lot of people are not necessarily aware, that I think they have a general idea, about that, and sure, that makes sense, but they don't know how it's actually done. How do you work at breaking cycles, of recidivism and relapse, and that lead to, repeated episodes of incarceration or repeated treatment episodes and these kinds of things, and all the comorbidities and the healthcare cost and population health issues. I think at the many times, the people who play who are the tip of the spear, in helping to coordinate those community resources, because they're not easy to navigate. People don't necessarily know they're there, that they need help, in helping people access them, perhaps get transportation to them, all of these various things. There's a treatment provider community, and in many cases that could be nonprofit, mission-based, treatment providers. It can be, for-profit, private treatment provider organizations, but the behavioral healthcare provider organization oftentimes are the people who are leading the way in coordinating not only their services, but with these, available community resources. And this is what allows them to provide, if you will, a continuum of care. Or we talk about recovery-oriented systems of care, in which, you're looking at the bigger picture.
We also talk about recovery capital.
Absolutely. That's it. And for people who don't have that recovery capital, these are the folks that are oftentimes helping bridge those gaps so that you can stop those cycles. How do we reduce the repeated traumas? How do we get people, so, I mean, it seems to me that there's this, by doing this, there's a self-defeating mechanism, in baked into this proposed budget that kind of does away with a lot of the really important resources there at the community level, perhaps.
You know what this budget shows to me? There's a saying, and I may have used this before because it's one of my favorites. I may have used it on the last podcast. Government works best when no one realizes it's working. It's very popular for both citizens and politicians to rail against the government. Even members of Congress who are part of Congress will rail against the federal government, say it's too big, it's too intrusive, too regulatory. As I like to say, and journalists have a saying, we don't cover the planes that land. So when things are going smoothly, when the potholes on your road have been repaired, when the trees have been taken off the highways after a hurricane, when you've eaten your turkey sandwich for lunch and not gotten listeria because the food inspectors did their job, no one notices that. But that's government. That is regulation. And it's good and it works. And this is a perfect example of that. These services that people take for granted in communities have no idea that the federal government plays a role in it. Why? Because the federal funding goes to the state goes to the community, and it trickles down. And even people within the state sometimes people within the counties who get this funding don't realize it's federal because it comes to them in the form of state funding. So they don't even realize what its origin is. But in large part, yes, the money does trickle down. So people in communities may not even realize what kind of jeopardy these programs could be in. And people who make these decisions, members of Congress who will vote and discuss and talk about this document, probably don't realize. It's interesting because when it comes to something like transportation, everyone knows the government's responsible for roads. When it comes to SUD, not every member of Congress knows the role government plays. I guarantee you there are several, if not hundreds of members of Congress who honestly, and through no fault of their own, honestly think the way you get treated for SUD is to go to a meeting.
Right.
Or you get 28-day inpatient like Sandra Bullock in the movies or whoever else. You get your treatment and you're sober. and you go to meetings, and that's it. But that's not it, as you and I both know. That's not it, and it really leads to get back to the social determinants and the role of the social services and recovery capital. Too many policymakers think that the ultimate goal of all of these programs is sobriety. While sobriety is an admirable goal, to people like me who represent the recovery community, I have come to learn it's not so much about sobriety as much about having control over your life and getting your life back, having that job, that home. Because that's why we want people in recovery.
Absolutely.
We don't want you to be in recovery for the sake of it. We want you to be in recovery so you can live your life.
That's right.
So take two very black and white examples. Let's say someone has an issue with their recovery and they unfortunately use. And they get drug tested and they get pinged and they could lose their job or their public housing or whatever as a result of it. Is that what we're after? Because you used, you need to be punished? Or is what we're after a system where you can call your peer, you can call your counselor and say, I made a mistake or something went wrong, but if you can help me, I know I can keep my job. I can keep my home. I can get through this. That's what we're after. We're not after sobriety. We're after a life you can live. As Charlie Curry, my friend at SAMHSA, used to say, his saying was, a life in the community for everyone.
Yeah.
Can you live your life? That's the goal we're after. We're not after sobriety for sobriety's sake. We're after sobriety for the sake of you living your best life.
Absolutely.
Like heart health. Why? So you can be there for your kids. Cancer cures. Why? So you could be there for your family and live your life. It's the same as the rest of public health. Be healthy so you can live your life, not just being healthy for the sake of it.
Absolutely. Outcomes are holistic things, and should be looked at that way. And so and here again, I just want to quickly bridge off, into, I had maybe a couple of key points just to touch on if we can, and I think that's a hugely, hugely important thing that you just touched on. And that we just covered it, because again, the current approaches to addressing behavioral health disorders seem to acknowledge all of what we just talked about, that you just mentioned. How there is an interconnection with those social determinants and how we need to address human beings, and we need to protect resilience. We need to give people the ability to remain in recovery, not to worry about a loss of freedom and loss of career and all these various things. I guess just kind of bridging over, and so this proposal, again, if it goes through, does not seem to have that same approach. Perhaps it's questionable, whether that would support the same thing. I wanted to kind of move into, are there things that you think the treatment provider community, does this really impact treatment? I mean, what are the aspects of this proposal that you should think about if you're any kind of a behavioral healthcare provider?
Yeah, I can't say how it affects treatment in terms of modalities.
Sure. Yeah.
It affects it affects the ecosystem, at least the world. I'm a Beltway guy. I'm a policy guy in Ivory Tower, whatever you want to call it. If you've ever seen an Ivory Tower, let me know. But I'm inside the Beltway, and I try as much as I can to get outside the Beltway. The people I work with, the people I represent, to say, show me around, show me what you do. It makes me a better. But from my perspective, since we're talking policy, it impacts the ecosystem. I mentioned before about the opioid epidemic and how it made everybody more politically aware of this SUD issue. And we have, for those of us who were around before and after, I remember the days of fighting. We're still fighting for scraps, of just like where the best you could hope for from a Hill meeting was to educate someone. Do you know more about SUD? Forget goals about funding. Do you know more than when I came in the door? Have I piqued your interest? Is this something you can stick with? And we made so much progress. We feel, even though we feel like we're not funded at the level we should be, we feel like part of the public health policy machine. When people talk public health, they now talk about behavioral health, whereas pre-pandemic, they didn't. We were an afterthought. Oh, we'll get to it, So
huge win there. Yeah.
Right. So now we're like, now I know people who work on CDC, who work on HRSA, who work on NIH, they come to people like me and my colleagues and say, what is SAMHSA doing in all this? How is SAMHSA affected by all this? Whereas they used to not. For providers outside the Beltway, if that stops, there will be, I believe, a trickle-down effect. There will be less research, less best practices. An organization like SAMHSA and all, an agency like SAMHSA and all the programs I just talked about, it's not just funding. They have publications on best practices, on clinical models, workforce models, everything we've done in the last 10 years on the development of the peer workforce. SAMHSA has worked tirelessly, host conferences, get gatherings, publications. What does it mean to be a peer? What are the best practices for a peer? What are the standards for a peer? They facilitated it. We would be losing, providers outside the Beltway would be losing that guidance and the benefits of that. When a provider outside the Beltway says, hey, we should expand our peer practice, let's hire some, they don't stop to think it was SAMHSA that helped, with all of their guidance, help this profession become what it's become. And that's just one example. When it comes to medication-assisted treatment and the explosion we've seen and the acceptance we've seen in buprenorphine, in methadone, and all the other FDA-approved medications, the guidance that, SAMHSA will say, best practices, best, it's kind of, SAMHSA has always been, in addition to a funder of the block grant, a clearinghouse of great information, of up-to-date information on where the field is and a particular issue. And if we lose that, we're going to lose knowledge. The convening of experts is what SAMHSA always did well. I would be in those rooms and people from all over the country, because I can tell you the best way forward for the communities in California is not the best way forward for the communities in Rhode Island. And even in California, northern and southern, the best way forward for the tribal communities is not the best way forward for the urban communities. SAMHSA would be a convener of experts to say, we need to be aware of cultural differences. We need to be aware of geographic, demographic, all of the different possibilities so that the services that are being provided outside the Beltway can apply the best practices. If we lose an agency like SAMHSA, I am afraid of not so much, there's funding. Yeah, there's losing the funding. But I am afraid of that beacon of convening of experts and guidance for this field that has exploded in influence in the last 15 years. I'm afraid of that going.
Yeah, and that's how we can very quickly lead into regression in thinking, and a huge loss, of that brain trust is hugely important. It's how we understand the world today and how to move forward. So again, that's when you talk about moving backward. I mean, that's a real risk. If you could quickly touch on, you brought up Medicaid, a little bit ago, and I know they're different things. Does this affect that, or is this connected in any way to Medicaid?
It's not connected physically in terms of the silos. It's connected politically because as Congress is trying to have a fiscal message of cuts and responsibility and whatever you want to call it, there's that mindset. But they're not connected legislatively, or they're in two very different silos. It's funny you should mention that because I don't expect anyone to know that when I mentioned the HHS budget for FY26, people who I work with who are quite intelligent and knowledgeable said, what does it say about Medicaid? The answer is nothing, because Medicaid's a totally different beast. Medicaid is being addressed through what we call the reconciliation process, which is also currently ongoing. The point we're at now, they've jumped through their procedural hoops. Now, both the House and Senate have to hit certain benchmarks of savings in order to pay for the policy priorities of President Trump. In the House and Senate, the House Energy and Commerce Committee, the Senate, I believe, Help Committee, has to find $880 billion worth of savings. And they have to find it from the Treasury, not from all these programs. What I'm talking about are what we call discretionary programs. They need to find it from the Treasury, which is Medicare, Medicaid, Social Security, veterans benefits, something called SNAP, Supplemental Nutritional Assistance Program, which we call food stamps. They need to go through these programs, and that's where they need to find the savings. That
Wow.
$880 billion that the House Energy and Commerce Committee is committed to finding in cuts, the math does not add up unless they muck with Medicaid. Now, they say they're not going to cut from Medicaid. They're going to reform Medicaid. Say what you will, work requirements, weeding out waste and abuse. You can tell what I think about that. The chatter we're hearing from Capitol Hill is that they don't want to cut benefits, but they do want to put guardrails and circuit breakers on certain expenditures for certain things, like the federal match for expansion states could be in play. One thing we all dread is something called per capita caps, which is, I don't know if I mentioned this in the last one, but you're the state of Ohio, you have this many people, the formula says you've spent this much on Medicaid the last few years, here's your money for the year, go have fun. And if in September the money's all gone, sorry, that's what a per capita cap is. And can you imagine if the ACA repeal in 2017 went into effect and per capita caps went into place and COVID hit? Can you imagine? Can you imagine in 2005 if per capita caps were in place and Louisiana was told this is all the money you get for the year and Katrina hit?
That's what we're talking about.
So the impact, let's say there's some kind of Medicaid cut somewhere. I don't know what it is. I don't know how much, but let's say there are these cuts. In the end, at the end of the day, the states lose out. The states have to make up that shortfall or make do with what they've got, which means they got to renegotiate rates. They got to renegotiate or not renegotiate, change reimbursements. And I got news for you. Heart health, lung health, cancer, those aren't getting cut first. What's at the bottom of the list?
Yep.
We are. And they're going to say we can't pay for these services or we can't pay as much for these services. And the dominoes fall. We start to lose workforce. We start to have to close facilities, on and on and on. So if you can believe it, the Medicaid fight we need to have is a bigger fight than everything we've talked about for the past hour, because the block grants that I've talked about don't hold a candle to what Medicaid covers in SUD. Oh. Medicaid, number one. Without Medicaid, there's no SUD treatment in this country, no public SUD treatment in this country. The block grant just fills in the gaps. So yeah, Medicaid's an even bigger fight. Now, we've been hearing the moderates are pushing back. We've been hearing doesn't have the votes in the Senate. I'll believe it when things start to really happen.
Yeah.
Sometime in the next few weeks, we are going to see exactly what the House proposal is. Mm-hmm. And then we'll have an idea of where the battle lines are drawn. And if you think I'm being overdramatic by using terminology like battle lines, I'm sorry, I'm not. This is a war to save Medicaid. And it is a knockdown, drag out fight. And the only justification I have for saying that is I lived through and worked through the attempted repeal of the ACA in 2017. And I will say it wasn't the repeal of the ACA that had me terrified, although I didn't like it. It was replacing it with the per capita caps. That's what had us terrified. So we'll see what happens. The chair of the Energy and Commerce Committee, Mr. Guthrie of Kentucky, is a very knowledgeable legislator and really knows his stuff. The chair of the Health Subcommittee, Mr. Carter, very conservative, has been, for the most part, an ally of the SUD community, but I can't say with confidence he's a big fan of Medicaid in general. So we're going to have to see what kind of deals Mr. Guthrie and Mr. Carter make with each other before we know any more. And then there's the moderates. There's the New York, California. I can't see New York, California, Pennsylvania Republicans going home for the midterms and having to face an electorate that had their Medicaid. I mean, people automatically assume that Medicaid's for the poor. 92% of all people with Medicaid already work. So I don't know what this work requirement thing is.
But also, it doesn't cover something like 60% of births in the U.S. or something like that?
Over 50% of all neonatal care and births in the United States bill Medicaid in one form or another. Not 100%, but 50% of all births in the United States, Medicaid will play a role in some part of the procedure. Yes.
So this is obviously it's another huge deep issue. Maybe there's another opportunity to talk about that. I think that's hugely important. Let me ask you, and again, I want to thank you so much for sharing your incredible depth of expertise on this issue and helping to understand what's at stake, what it may mean. The last time you left off with kind of a canary in the coal mine, what should we watch out for? And it happened to be this budget, and it just so happens that I guess we all got a peek of the budget or the proposed budget, before it actually may have been intended to come out. What's the next thing that we should be watchful for?
The budget still needs to be in final form. So sometime in the next, the chatter seems to be two weeks, the actual budget to Congress. You will see members of Congress, especially appropriators, give quips in the press, like, maybe the House Republicans will be like, oh, it's everything we wanted. The House Democrats, oh, this is awful. Let's see what the Senate has. So Senate reaction to the budget will be one. On the Medicaid front, it's like I said, let's see what the House Energy and Commerce Committee does in their proposal. That's two. Those are going to be the things we look for. They should be coming up soon. And then after that, in normal times, the House and Senate release their appropriations documents like early June. I don't think they'll meet that there's not enough time. Sometime before the August recess, let's see what the House and Senate produce in their appropriations documents. Those are the three big things.
Okay. Thank you. Well, we'll keep our fingers crossed and hope that things...
Whatever altar you pray at, whatever God you sacrifice to, whatever your spiritual beliefs are, we'll take anything.
Absolutely. Yeah. Well, I think we'll leave it there for now. Again, thank you so much. Really appreciate it. Wish you the very best of luck in continuing, to do your work in advocating for this very important issue. So
absolutely.
Thank you so much, Andrew.
Thanks for your time, Chris.
All right. Take care.